I'm going to just take things down a little bit of a tone just before I introduce Ben, because Peter started his introduction by presenting some statistics. And, it was pretty shocking when you think about the numbers of people in our community who have serious mental health problems and the percentage of people who are not getting adequate treatment. But it's actually significantly worse than Peter even described. So if you are a teenage girl who uses social media, how many of our teenage girls don't use social media? If you're a teenage girl who uses social media, you have a 50% chance at the moment, by the time you exit adolescence, that you will have a diagnosable mental health condition. Not 1 in 4, not 1 in 5, 50%. And it's not that much worse, not that much better for males. So here at the university, we have 8,000 students who live on campus. In the coming years, we will have between 3,500 and 4,000 students living on our campus in our halls of residence who have clinically diagnosable mental health problems. Not just mental health distress, we're talking about significant depression, anxiety disorders, eating disorders, etc. So we don't just have a static problem, we have a significant cohort of individuals which at the moment looks about 7 or 8 years wide. So anybody sort of from about 2013, 2014 onwards, which along with a whole range of other sort of social and economic issues happens to have coincided with really the explosion of the use of social media. You have this significant escalation of the rates of mental illness. And if you couple that with the fact that for that 50% of people, if you remember what Peter said, these are conditions that for a lot of people are lifelong. So that 50% of people when they're 20, it's going to be 50% when they're 30 and 40 and 50 and 60. And so these are really, really significant societal problems. I don't think anybody's really started to think at a societal level yet. Even here in the university, what does it mean if I'm a lecturer in the law faculty talking about anything really, and half of the people in the audience listening to me have got significant problems maybe with their attention because they're suffering from depression, or their ability to focus and concentrate because they're suffering from anxiety, let alone what that means for social interactions, etc. You can think about a whole range of expanding issues related to that. So we desperately need solutions at a societal level, and we need solutions at a clinical level. And that's what we'll obviously hear about this evening. It's with great pleasure I'm going to introduce the speaker for the evening, because you're not here to listen to me or to Peter, you're here to listen to Dr. Ben Sessa. Ben has been really at the forefront of both psychedelic and cannabis-related medicine since he trained in medical school and then as a psychiatry trainee at Imperial College London over 25 years ago. He started his experience in doing research in this space, became a child and adolescent psychiatrist, and has worked with a whole range of psychedelic and other novel medicines in clinical trials and in the development of services both for patients with depression, PTSD and addiction and other conditions. He's done research with LSD, with psilocybin, with DMT, with ketamine and MDMA, all within the construct of developing novel protocols and clinical trials. And I can tell you from our experience here, it is really, really difficult to do research in this space. You hit up against all sorts of regulatory roadblocks, and it just takes an enormous amount of commitment and persistence to do the sort of work that Ben has done. Along the way, he helped found Awaken Life Sciences, a biotech company carrying out psychedelic research particularly focused on addictions, but also which opened a number of clinical service and research centres in the UK and Europe, providing psychedelic treatment with ketamine and an environment where some of these clinical trials could take place. And somewhere amongst doing all of that, he's also found time to run conferences in this space, as well as to author a wide range of academic articles, but also a number of novels as well. So he's certainly highly productive and really has substantially contributed to this space. And with great pleasure, I welcome him to speak to us this evening.
Hello, everybody. Good evening. Thank you very much for having me. Thank you, Paul. Thank you, Peter. Thank you, this wonderful place, ANU. I love this room, the tank. Great lecture theatre. I think long after everything else on earth has been destroyed, this will still be here. I've been here for about 4 or 5 weeks in Australia doing these retreats for Mind Medicine Australia, and in this last week doing this whistle-stop tour of lectures and workshops in Melbourne, Sydney and Canberra. And I'm here for a very good reason. I am here because I am deeply envious and jealous of all of you lot. It's not fair. We in the rest of the world have been struggling in psychedelic research for the last 20, 30 years in modern times. And Australia, it's fair to say, hasn't really been much on the map in this area of research. And then suddenly, out of nowhere, from the left field, on the 1st of February this year, you win the prize. You are the first place in the whole world where you can use MDMA and psilocybin as medicines. Now, of course, you can use MDMA, psilocybin, DMT, ketamine, 5-MeO, DMT, salvia, ibogaine, all the rest of them in research protocols anywhere in the world. As Paul says, research is a pain. It's expensive, it's laborious, it's full of restrictions. You can only do a very small N number of people, 10, 12, 15, 20 people, cost you $2 million to do a study like that. And it's not really got anywhere. And I've become increasingly frustrated over the last 15, 20 years that I've been working in this space. My colleagues and friends in the States who are leading MDMA research and psilocybin research, every time I speak to them, they always say, Ben, one more year, another $20 million and it'll happen. And I've been listening to that for 15 years. And so I have followed my nose to where it's at, and that's here in Australia. You have leapt into the front of the race. You are in first place. You are leading the rest of the world. You have an unrivaled opportunity that lies ahead of you. You have a 3-year head start on the rest of the world. Nobody else can do what you've just done with TGA. Even if they start tomorrow, it's going to take them 3 years. And I'm still not, I will believe it when I see it, when FDA and EMA and MHRA license MDMA and then psilocybin. So it is here, it is happening. It can happen tomorrow. You can build a clinic and start giving MDMA tomorrow, sort of. It's going to have a little bit of red tape to get through. But let's not forget that. And one of the things we're going to talk about tonight, it's a bit of an introduction basically into psychedelics, and forgive me if there's some experienced psychonauts in the room who know all of this. I'm sure there always are. I'm going to do some basic stuff. I'm going to talk about what psychedelic therapy is, how it works, how the drugs work, how we use them in combination with therapy. Talk a little bit about this situation in Australia, and a little bit about politics and plans going forward. But the thing I want you to take away from here, more than anything, I've spent my life talking to groups of people like this about psychedelics. And if I talk to a room of 100 people in Europe or America 5, 10, 15 years ago, I might look out at this 100 people of interested academics, stoned hippies, people who just want to learn a little bit, and maybe 1 or 2 out of that 100 will actually ever work with psychedelics. Now, I look at this audience. 40, 50, 60 of you could actually be prescribing and treating and using psychedelics with your patients in the next 6 to 12 months. That's extraordinary. That's something I've never had. It changes my whole focus of teaching. This isn't just teaching. This is preparing and training people to go forth and start treating patients. So we need to turn this academic, theoretical interest into real bricks and mortar clinics and start treating patients, because no one else can do it. So let's get cracking. So thank you for that introduction, Paul. I think what I would add to that is, as a child and adolescent psychiatrist, I've always taken a very developmental view of my work. And so after working with maltreated and abused children for 10 or 15 years, I then went into adult addictions. And that was a very natural developmental trajectory for me, because that's the developmental trajectory for my patients. And those people in their 20s, 30s, 40s, 50s with alcohol, opiate addictions, benzo addictions, they were the same cohort of grown-up kids who I looked after when they were 4 or 5 years old and being hurt and humiliated. And they moved towards those substances. People don't want pain. I don't want pain. If I'm in pain, I'll take a painkiller. And if my pain is severe, I'll take vodka and I'll take heroin, because they're the best out there. And this is why we have these problems with substance misuse. The vast majority of people with substance misuse are traumatized people. So we lose sight, we miss the wood for the trees when we ban drugs and we ban substances. What we really need to be doing is treating people with trauma. And we're going to look at this concept of trauma as we go through the evening. So let's focus on a couple of these drugs. Now, there's a whole bunch of psychedelic drugs, and they're all classified in different ways. We're going to focus on psilocybin, MDMA, and a little bit on ketamine this evening, because it's psilocybin and MDMA that are the target for the TGA directive that you've very excitedly got. So if we talk about psychedelics, sometimes people use the term classic psychedelics, and that means these ones like LSD, DMT, 5-MeO, etc. These are 5-HT2A partial agonists, and some people only use the word psychedelic to mean these. You don't have to do that. I would ask you to broaden your appreciation of what we mean by psychedelics. And if we want to talk about those ones, the 5-HT2A partial agonists, let's call them classic psychedelics, because there's a whole bunch of other drugs that are psychedelic. The entactogens is another group, of which MDMA is the most well-known. The 2C series, 2CB, 2C7, etc., are also in that same group. They're psychedelic. The dissociative anesthetics, of which ketamine is the most well-known, is another group. And then there's a whole bunch of other stuff like salvia and ibogaine. And I would argue tetrahydrocannabinol is psychedelic. Trust me, try 15 milligrams of intravenous THC with no balancing CBD and tell me that's not psychedelic. It is. So we have to broaden our appreciation of what we mean by psychedelic. And I guess what we mean is drugs that alter our state of consciousness. You're in a waking state, but your consciousness is a different level. It's difficult to even describe what that means. And we'll try and get there in understanding what that means as we go through the night. Ketamine, just a very brief word about ketamine, because I'm not going to say too much about it. Ketamine is not new. Ketamine is a well-known anesthetic. It's been around since the early 70s. Very helpful anesthetic, very safe, very short-acting, doesn't interact with any other drugs. It's the anesthetic of choice in children and in the elderly or anyone whether you don't know someone's medical history or their drug history. So it's been around for a long time as an anesthetic. And then about 15 years ago, serendipitously, an anaesthetist who was giving ketamine to their surgical patients discovered that those with depression seemed to have a brighter mood for about 2 to 6 days after ketamine anesthesia. This is wonderful for two reasons. Firstly, it gave birth to this whole concept of using ketamine as a rapid-acting antidepressant, and it's a really useful rapid-acting antidepressant, even without associated psychotherapy. The second thing that's remarkable about this is that there's anaesthetists out there who are interested in mental health issues. So that came as a big surprise to me. Now, what psychedelic therapies do we use and what are they used for? If we look at the way research has gone over the last 20 years or so, we've seen psilocybin applied to anxiety, to addictions with AUD there. Obviously, the work done by the Multidisciplinary Association for Psychedelic Studies developing MDMA-assisted psychotherapy for PTSD is the furthest along of all of the research in the world. Alicia Danforth looked at social anxiety disorder in adults with autism with MDMA. That's my study in the UK, in Bristol, using MDMA-assisted psychotherapy for alcohol use disorder. Goodwin's study is the person behind the Compass Pathways Initiative, which is the furthest ahead in bringing psilocybin for TRD forward. Meg Spriggs at Imperial is looking at psilocybin for anorexia nervosa. And Steve Ross looking at psilocybin for PTSD. We've then got a few studies that are still in the planning, MDMA for emotionally unstable personality disorder and eating disorders, psilocybin for personality disorder, and a couple of studies that are starting up looking at MDMA with depression. So what are we seeing here? What we're seeing is a couple of drugs here which appear to have a broad spectrum approach to multiple psychiatric indications. That's kind of weird. And it's strange to think how this is going to be taken on in terms of drug approval agencies and in terms of funding drug studies. Because mostly we've targeted a particular indication with a particular drug of a particular class. What we've got is multiple indications being treated by psilocybin and MDMA. And of course, ketamine appears to work for all of them in a small handful of pilot studies that have been done. So broad spectrum treatment across multiple indications. What this tells us then Despite our reading of the DSM and the ICD and the fact that mental disorders appear to fit into different categories, what this tells us is that psychedelics appear to be working across the board as non-specific amplifiers of psychotherapy. This is very exciting because this means that any psychiatric illness that's currently treated by psychotherapy, which is every psychiatric illness, from addictions to personality disorders to anxiety disorders, affective disorders, PTSD, all of them involve psychotherapy programs, and it's arguable that psychedelic psychotherapy will be even better than the current treatment. So this illustrates the broad spectrum effects of psychedelics. Now, there are a couple of exclusion issues here. Psychosis is generally excluded from people on psychedelic programs. So that's schizophrenia, bipolar I disorder, or history of drug-induced psychosis. And that is fairly understandable. There's obviously, one looks at the actions of psychedelics and think, well, these must be psychotogenic drugs. You know, it looks like psychosis. So these people have always traditionally been excluded from studies and will be excluded also from this TGA initiative. I think this will change in time. I think those of us who are clinicians in the room, admitting people through casualty with acute psychosis, we know what the biggest psychotogenic drugs are. They're cannabis, amphetamine, and cocaine. Those are the drugs that trigger psychotic episodes in people with a psychotic fragility, like schizophrenia, and brings them into hospital beds. You would think psychedelics would do this, and it's arguable that psychedelics could do this to some extent in that it's a peak experience, can be a highly stressful or difficult experience for someone, and that could trigger psychosis. But pharmacologically, the link between psychedelics and psychosis is not particularly strong. And very interestingly, as recently as a couple of weeks ago, I spoke to a colleague of mine, Dr. Julie Holland in New York. She's about to submit a protocol using MDMA-assisted psychotherapy in the treatment of people with schizophrenia. So watch this space regarding psychosis. So what's going on here? You're ahead of the rest of the world. That's the first thing to say. And the second thing to say is, well done, Peter and Tanya and MMA. There's a lot of competing forces here in Australia, but you have to take your hat off to what's happened here in Australia with this decision. I'm still kind of suspicious as to how you got it over the line, to be honest. It was hard work, it was money, it was energy, it was effort, and it was persistence. And it happened. You know, all over the world, we have quite a lack of parity around drug policy, with different countries and territories having very different approaches to drugs. In some countries, they have legal psilocybin available. In others, they have medical cannabis or recreational cannabis. In some, we have needle exchanges for heroin users. In some, we cut off people's arms if they smell of cannabis. It's an extraordinary lack of parity around the world, which doesn't make sense when we have a United Nations Charter 1971 that says what they should all be banned. Individual nation states have autonomy over how they set domestic drug policy, which to me makes the whole thing a bit of a farce. They're either really bad for you and dangerous and should all be banned, or we should have more unprohibitive strategies. The fact that different countries have different strategies really says something about what's going on here. Where's the science? Where's the science behind this? So one way or the other, you managed to get it over the line here in Australia. Hats off to your government to take that courageous decision. Because most governments everywhere maintain this hard line, don't be soft on drugs. Well, there's nothing softer than prohibition. Drugs don't kill people. Prohibition kills people. Every single drug death I've ever been involved in my career has been due to the prohibitive stance of that drug and the dangers and risks that go with that. Prohibition does not save lives. It kills people. It reduces access to services. It funds the mafia. It increases use of drugs, weirdly, and no one can quite understand that piece of data. Yet it persists, and I can't understand why it persists, to be honest. I can't think of any other branch of government legislation that has gone unchallenged since 1971. Since 1971, we've had complete overhaul of food, services, farming, transport, education, social services, health. All of these industries have moved on in response to evidence base. Yet we have the same drug laws as the day they were written in 1971. Extraordinary. Unscientific, dangerous, but for your country here, taking the brave move. And what they have done it's important to say, MDMA and psilocybin are not approved in the capital A sense of the word. They have been rescheduled, taken out of the Schedule 8, meaning that they're poisons, they're dangerous, they're banned, they have no medical use, out of Schedule 9 into Schedule 8. Now, I say that you've done this ahead of the rest of the world. It's fair to say this decision was made on the basis of the data from international studies. So groups like MAPS and Compass and others have worked with the TGA and with MMA to provide data and get this over the line. And so it is on the basis of that international research that the TGA say they have established therapeutic value. So whilst they're not fully approved, they have enough established therapeutic value and safety to move forward with starting them in treatments. Now, treatment, as I said, is different from research. Treatment's a lot easier. There's still a lot of scrutiny and supervision and registration and licensing and everything else, but it's not nearly as difficult as research. Now, in order to move forward with this, there's a number of people within a multidisciplinary team that need to be involved. Doctors, nurses, psychotherapists, counselors, pharmacists, team managers, administration people, pharmacovigilance experts. Delivering mental health care is a multidisciplinary effort. The doctors need to become approved prescribers. These must be psychiatrists. Psychiatrists are required because they need to carry out assessments and eligibility checks before people go into the schemes, and they also need to prescribe. But it's not appropriate that doctors are the therapists. I mean, most psychiatrists make fairly lousy therapists, to be honest. Any clinical psychologist will tell you that. And so that's left to clinical psychologists, counselors, and therapists. Many people involved. One of the things the TGA stresses is that people must have robust training. And they don't say who ought to do the training, which group, which is great, fair enough. I'm not being biased when I say Mind Medicine Australia is ahead of the pack. It has, as Peter said, from David Nutt's words, the best, most robust training in Australia, if not the world. The 14-week online course followed by the week residential training. It well and truly ticks the box for TGA that you have done enough training to move forward. So very important to undergo that training. Now let's focus a little bit on some of these compounds. Firstly, this one, quite remarkable, molecule 3,4-methylendoxymethamphetamine. It is a phenethylamine. It's a synthetic psychedelic entactogen, not one of the classic psychedelics. I'm not even going to mention the E word once tonight. It's short-acting, about 4 to 6 hours. It's not a classic psychedelic. It doesn't have that perceptual disturbance. You maintain your ego, your sense of self. It's primarily an affective drug. It's a heart-opening, warm experience. It's almost always pleasurable. That's very, very important. There are a few drugs in psychopharmacology that have invariable pleasure. Opiates are one. Sometimes when I'm teaching medical students, I say, if you don't like heroin, you don't have a brain. You really need to talk to a neurologist because there's something wrong with your wiring. Now, I'm not encouraging people to use recreational street heroin here. I'm making a point about tolerability. MDMA is very tolerable. You don't really have a bad trip with MDMA. It either works or it doesn't. And it's this positive experience of warm open-heartedness, this sense of empathy. That's what's so important. It allows you to recall painful, traumatic memories that you would normally avoid. And this, therefore, makes it the holy grail for psychotherapy. If you were going to invent a drug for trauma-focused psychotherapy, you would come up with MDMA. Psychotherapy is difficult. You reach a brick wall with psychotherapy. You can talk about your pain and your relationships, and then you hit a brick wall with your therapist when your therapist says, so, tell me about that night when you were 8 years old and your grandfather came into your bedroom. And you freeze, and you drop out, and you go back to the heroin, and you go back to the vodka. Because by the time you're in therapy in your 30s, 40s, 50s, you have become an absolute expert at avoiding those traumatic memories. You will do anything but go there to that thing. And you drop out. And we have 60% treatment resistance in PTSD, 90% treatment resistance in addictions. This is not good enough. After 100 years of modern psychiatry, we should be doing better. I can't think of any other branches of medicine that would accept these kinds of outcomes. It's just not good enough. And it's certainly not good enough when we have something that could change those awful statistics that Paul mentioned. Psilocybin, now this is different. This is a classic psychedelic drug, same as LSD and DMT, 5-HT2A partial agonist. Works very similarly to LSD and DMT. We've done a lot of imaging studies at Imperial that demonstrate there's virtually identical experience, virtually identical mode of action to LSD and DMT, although anybody who's taken LSD, DMT, or psilocybin will know that they do have different qualities, particularly DMT. It's shorter acting than LSD, it's about 4 to 8 hours. It's found in many varieties of magic mushroom. Around 200, 300 varieties of magic mushroom contain psilocin and psilocybin. It's psilocin that has the effect in the brain, and psilocybin is converted to psilocin in the brain, in the gut rather. There are many, many different types of magic mushrooms. I've chosen this one, the famous Australian gold top. Reminds me of backpacking around Australia when I was 18. I came to Canberra. I had really long hair and flowery trousers at the time. I'm much younger now. Very, very safe, the classic psychedelics, very safe. LSD, psilocybin, virtually inert physiologically. Don't really do anything to the body. Transient rise in heart rate, which is probably anxiety-related, not pharmacologically related. This makes it a very useful compound to work with clinically, because you're not going to overdose the patient from a toxicity point of view with this drug. You have to take 1,000 times the typical recreational or clinical dose to get anywhere near the LD50, which is the toxicity way in which we measure toxicity of drugs, which equates to 17 kilograms of fresh mushrooms. Now, how and why does psychedelic therapy work? Well, in order to understand this, forgive me, the child psychiatrist coming out here, we need to talk about childhood trauma. Now, when we talk about trauma, people often think about sexual abuse, physical abuse, the biggies that hit the social services radar. I say don't take your eye off the ball when it comes to emotional abuse and neglect. I don't love you. Your dad doesn't love you. You're stupid. We didn't want a boy, we wanted a girl. You're fat. You're ugly. Everyone's lying to you. Everyone hates you. No one's being sexually abused here, or physically abused, but that drip, drip, drip emotional abuse from the age of 12 months onwards is profoundly damaging to a child's development, profoundly damaging to an adult's personality development. And this is because of this disruption to the attachment relationship. Now, child psychiatrists bang on about two things. Number one, boundaries. Number two, attachment. They love it. Attachment, this beautiful reciprocal dance between the primary caregiver and the pre-verbal child. It's where we form the fundamentals of self. It's where we form the narratives of what is love, what is trust, what is friendship, what is a brother, what is a mother, what is a father. Is it okay to lie? Is it okay to steal? Is it okay to drop litter? We learn this stuff when we're that high, and we don't really lose it. We don't ever lose it. We keep those same fundamental parts of self. And also our appreciation of the rest of the world. Can we trust people? Is it okay to lie to police officers? Is it okay to hit people? Is it okay to break the law? These are narratives. They form from early experience in this early blueprint relationship. And those people, if you're lucky enough to be cared for and cuddled and played with and praised and told you're beautiful and strong and clever, you're going to probably have very good resilience to adult mental health in terms of not getting ill. And if you haven't, your risk of adult mental disorder is hugely increased. It's by far the greatest effect size in all of psychiatric epidemiology, is the relationship between disordered attachment and adult mental disorder. Now, those of us that work with patients also know there are multiple psychosocial risk factors. There's also genetics. The genes are not fairly distributed. It's not very fair, is it? All the nice posh people who live at the top of the hill and go to the posh schools and have the wonderful families and all the money and the great education and the job opportunities, they've got all the best genes. They cluster up there. And all the people who live down the hill in the ghetto with the poor education and the difficult families and the substance use communities and the unemployment and the racism and the exclusion, that's where the depression, anxiety, PTSD and addiction genes cluster. Maybe we should practice eugenics and get them all to mate with each other. So I'm not suggesting that, by the way, before anyone suggests I'm putting some right-wing, The point is it's not fair. The point is it's a double, triple, quadruple whammy when it comes to risk factors. And you really need multiple risk factors to actually display the end phenotype, which is the mental disorder. Now that sounds very depressing. And Peter described this as a palliative care approach. We get alongside our patients. We don't cure them. Because the truth is, if you're coming in to see your psychiatrist in your early 20s with a child trauma-related anxiety-based disorder like PTSD or addictions, you are going to be talking to that psychiatrist in your 70s. That is not good enough after 100 years of modern psychiatry. It's outrageous. So we have this stuckness. One of the reasons we have this stuckness, as Peter alluded to this, is we tend to treat people symptomatically. If they're depressed, we give them an antidepressant. If they can't sleep, we give them a hypnotic. If their mood goes up and down, we'll give them a mood stabilizer. If their hypervigilance, one of the core features of PTSD, becomes paranoid, we'll give them an antipsychotic. 4 different classes of drugs. Let's add another one. If they're constantly anxious, we'll give them a long-acting benzo. 5 different classes of drugs. None of them are curing them. They're treating the overlying symptoms. The issue is trauma. So let's take an analogy. Let's imagine you have an infection due to a bug, a microorganism. One of the symptoms of an infection is a high temperature, pyrexia. It's uncomfortable to have a high temperature. So you can take ibuprofen or paracetamol. It will bring your temperature down. You'll feel a bit better. Good for you. Now, ibuprofen and paracetamol are not antibiotics. They're not going to kill the bug, but they're going to make you feel a bit better because you're treating the symptom of high temperature. When we tank our patients up symptomatically with SSRIs, mood stabilizers, etc., we are treating their temperatures. We are treating one of the symptoms that's being expressed due to the underlying cause, which is trauma. Where is our antibiotic? And you can see where this is going. How do we disrupt this? This is what we call the entropic theory of brain. It's quite popularized by Robin Carhart-Harris, one of my colleagues at Imperial, or was. He was a young, fresh-faced PhD student when I first met him, and we did the UK's first psilocybin study together when Robin stood there with a clipboard and David Nutt injected me with intravenous psilocybin. Inside a mock wooden MRI scanner. It was the beginning of the research we were doing in Bristol. So this room here, ordered, neat, tidy, requires a lot of energy. That's what we call a low entropy state. Highly organized, like a cup of coffee is a low entropy state. A closed system, full of energy, took energy to create it, and it's very organized. The natural law of the universe, if you just live in that room, you move towards this room, like one of the 8,000 campus rooms in this university, no doubt. A student room. If you don't keep putting energy in, the information dissipates, becomes untidy, becomes chaotic, it's not ordered. Now, how this relates to brain, the theory being that highly organized low entropy state is analogous to this highly rigid mental state. The stuckness, the high rigidity that comes from the trauma issues I talked about. I am useless, I am a failure, there is no other answer, you can't talk me out of it. No amount of psychotherapy is going to work because I know how awful I am. You're stuck, you're rigid, you're narrow. And we see this in ruminations around depression. You see it with addictions all the time, or OCD, those kinds of things. And the argument with psychedelics is a few precious hours spent in that chaos, chaotic though it may look, can be incredibly valuable if we then hone that experience into developing new ways of thinking. So it's a kind of holiday away from rigidity for a few very privileged hours. Now, you can't live in that room long. You don't want to be tripping all the time. It just wouldn't work. We need categories and boundaries and labels and rules. You can't, if you're always in that room, then you're going to step out in front of a bus and say, it's not a bus, it's a collection of vibrating energy particles. You can't stay like that forever. But for a few brief hours in a controlled setting, that could be valuable. And here's another way of looking at it. And again, this is research that's come out of Imperial. The placebo one there, the normal brain state, the colored areas are different regions of the brain, and there's a little bit of activity and networking between them, within them, and a little bit between them. On psychedelics, suddenly everything's open. Suddenly, huge amount of connectivity within regions and especially between regions. This is our messy bedroom. What this means is that anything's kind of possible. Those narratives are open to being broken. Now, the way brain works is quite important. The way brain learns is quite important. We don't actually learn things by learning what things are. We learn what they're not. And the infant brain is highly connected like that. Everything is anything. To an infant, this pointer could be a spaceship. Not just let's pretend or imagine it's a spaceship, it actually could be a spaceship. Now, I know this is a pointer, not because I've learned it's a pointer, but because I've learned it's not a spaceship, or a fork, or anything else. It's a pointer. I've whittled away all the various possibilities until I'm left with, this is a spaceship, the pointer. Sorry, I wish I hadn't had that second microdot. So this is very, very important. Now, you can't live in that space. You cannot live in that space. But if your narratives are so stuck, your uselessness, your worthlessness, then that holiday is valuable. So let's look at this 3 different drugs, psilocybin, ketamine, and MDMA. Now, 3 different drugs with 3 proposed different modes of action, although every month that goes by we get new neurobiology papers suggesting they might all do pretty much the same things at a neurobiological level. But let's keep it simple. Let's propose that psilocybin works by increasing this network of connectivity like I showed that picture. There's a default mode network. This is a part of the brain that we ruminate on, and it impairs that. So it turns that off, increases network connectivity. Ketamine induces protein synthesis, creates budding neurons. If you take a Petri dish with a slice of nervous tissue in it, you soak it in liquid ketamine, and you look at it under a time-lapse camera, you see dendrites budding, popping before your eyes. It's incredible. You actually see this connectivity. Dendrites are the connections between neurons, brain cells. Do you know how many neurons there are in a 1 millimeter cube of cerebral cortex? 1 millimeter, tiny little thing. 300 million neurons in a 1 millimeter cube. We learned that the other day. And each neuron has potentially 10,000 dendritic connections with other neurons. That's a really big number. So ketamine induces protein synthesis, providing dendrite growth, providing network connectivity. MDMA works slightly differently. MDMA turns off the amygdala. The amygdala is a part of the human brain where we process emotion, part of the limbic system. It's called the mammalian brain, or the midbrain sometimes. It's quite sophisticated. It's more sophisticated than the brainstem. The brainstem just looks after blood pressure, blood chemistry, heart rate, breathing. And then you go up the evolutionary scale, you get this thing called the midbrain, the amygdala. It's pretty good. It's pretty good system. It fires in response to fear. It's what we call a bottom-up process. There's no cognitive thought required. It's an instinctive knee-jerk reaction to fear. And then we go a bit further up the evolutionary scale, and we have this forebrain, or the neocortex, or the prefrontal cortex. This is our sophisticated human bit of the brain. Pretty much only humans have this. It's where we have our lofty human pursuits of logic and reasoning and planning and executive functioning. And this front of the brain, this human part of the brain, can overcome this amygdala response. And it can dampen down the fear response, but it doesn't if you've been experiencing trauma as a child. Because your amygdala is excessive. You find things more frightening, and you're no good at using your neocortex to dampen that. So even when you're grown up into adulthood and you're no longer being assaulted, you just find things scary. There's a queue at the post office and you have a panic attack and you believe you're being attacked when you're not. This is underpinning PTSD. Indeed, PTSD could be seen as the sign of a healthy brain. It's a natural adaptive response to a noxious environment. So I digress. Let's get back to our drugs. So 3 different drugs, 3 different modes of action. What they do is they all take us to the same place. For a few brief hours of opportunity, you open this window, and you'll hear these words, neuroplasticity, neuroflexibility, spoken often. Imagine, let me do some really basic neurology. If there's any neurologists in the audience, you'll shoot me. Let's imagine this here. This is your I am useless pathway in your brain. Now, brains are lazy. The more you use a pathway, the better it becomes and becomes more default. So if from the age of 2 months onwards, I've been told I am useless, I am useless, I am useless, it gets faster, it gets thicker, gets more and more dendritic connections. faster myelin sheath. It becomes your default pathways. It's very difficult to think of anything other than that. And that's why when your therapist asks you to explain that, you just can't. And this translates psychologically to these negative narratives. Now, let's imagine that we've got a skiing mountain covered in snow, and you always ski down the same track every day. You've been going down the same track every day, using this same I am useless pathway that's become thicker and deeper, this ski track. It's very difficult to get out of that ski track. Psychedelic drugs, neuroplasticity, is a fresh fall of snow on that mountain overnight. And the next day you come to ski and you get to the top of the mountain, you don't have to take that track. You can go anywhere you want, or you can go anywhere you want through that messy bedroom where anything's possible. So we have this brief window of opportunity. And if we hit the patient at that point with bespoke focused psychotherapy, we have the best new innovative piece of technology that we've known for 50 to 75 years to actually tackle these rigid narratives, to overcome that impediment that is treatment resistance, to allow those patients who cannot focus and access on psychotherapy to do so, because we've used the drug as a primer to put their brain into a state that they can then do psychotherapy with. And every month we have more papers coming out using words flexibility, plasticity. Psychedelic drugs are remarkably safe. As we've said, physiologically low, psychosis, low risk, suicide, low risk, dependency, they're not on these are not drugs on the radar for addiction services. We just don't see that. I worked for 12 years in a community team, didn't see any MDMA or psilocybin coming in through the doors. Nobody breaks into your house to steal your TV to get their next magic mushroom fix. It just doesn't happen. There are some rare conditions like HPPD, which are very rare. David Nutt did this famous Delphic analysis of 20 different compounds, and there's our psychedelics languishing at the bottom there. Very low risk to self or others. You'd have to eat 17 kilograms of magic mushrooms. What does that look like? Well, there's 200 grams of mushrooms. Somebody asked me in the last lecture, why did you use button mushrooms and not psilocybin mushrooms? Because they don't sell them in Tesco's. It's like... anyway, you'd need to eat 85 boxes of those to get anywhere near the toxicity index of LD50 for psilocybin. So, as we know, TGA have moved forward with this brave decision. They've chosen MDMA for PTSD and psilocybin for TRD because they're the most furthest along based on a whole bunch of studies which are either past phase 3 or going into phase 3. So those are the two conditions chosen. As we said, a doctor needs to carry out these assessment and eligibility checks, and it's pretty standard sort of procedure for psychopharmacology research in a way. Very important to clarify the diagnosis. You need to get the patient's medical notes and demonstrate they have the diagnosis. This is not a diagnostic system. This is treating people with an established diagnosis. Some people will require physical exams and blood tests and ECGs. Risk assessments are essential along the way, and also collecting outcome data, as Paul will no doubt talk a little bit more about. The inclusion criteria are basically having the disorder as corroborated from their medical notes. And the exclusion criteria are also, again, pretty standard for psychopharmacology research. Severe liver or renal disease, personal history of strokes or heart attacks, personal history or family history of psychosis, schizophrenia, bipolar 1, etc. Hypertension's fine as long as it's stable and they're on antihypertensives. Suicide, it's important to screen that out. Obviously, a lot of people are going to have a history of suicide or unstable self-harm, but you need them to be relatively stable to go through the treatment. So the cutoff we had was 3 months. Suicidal behavior in the preceding 3 months would make them ineligible. Pregnancy and breastfeeding obviously is a no-no. Low weight. Now, here's a kind of a very brief outline of what treatment protocols can look like. You can't read this, of course. The light green are the drug sessions, and the dark green are non-drug sessions, and the orange ones are prep or follow-up sessions. The top one is an example of a typical MDMA trial or treatment. 3 doses, 3 drug sessions spaced 2 weeks apart, each of them, with a next day session. The first week you will take 80 milligrams, following week 120, and following week 120, plus a half booster dose at each session. of MDMA. This is the MAPS phase 3 protocol, and most people setting up protocols for PTSD in Australia will choose this. Now, it's still a bit more up for grabs when it comes to psilocybin. Interestingly, the TGA didn't say you have to do the following protocol. Their exact words were something along the lines of, protocols must be roughly similar to established international research. That kind of leaves it open. And I think it'd be good if people all over Australia don't do exactly the same protocols. We can do subgroup analysis on those different protocols. With the psilocybin protocols, they're still a bit up in the air as to whether it should be 1 or 2 sessions of psilocybin. I quite favor 2, especially a low dose tester before the main threshold dose for people who are psychedelic naive. But what's most important about these protocols is that they're a combination of drug and non-drug sessions, absolutely important. It's not just taking the drug. Taking the drug's the easy bit. It's the non-drug prep sessions that come before taking the drug and the post-drug integration sessions. There's not a lot of talk therapy that takes place within drug sessions. Some, to some extent, with MDMA, but very little with psilocybin. It's much more about just keeping the person in the experience. That earlier slide of how the drug is the primer, creating this neuroflexic, neuroplastic brain. And it's those crucial non-drug sessions that are really important. And that's often what's missed out in recreational use. Well, it's always what's missed out in recreational use. People go to a festival, they take LSD, they come home, they don't have anyone to talk to about it. It's also missed out in a lot of underground settings. People fly off down to Peru, have high-dose ayahuasca, come back, and they haven't got anyone to talk to about it. Integration is crucial. And missing those bits out are at best unsafe and at worst untherapeutic, or maybe it should be the other way around. Now, we work within the psychedelic space. It's not just disinhibition. It's much more than that. It's much more focused and targeted than that. It's not just fear extinction with MDMA. Lots of drugs cause fear extinction. Heroin, alcohol cause fear extinction, but they're messy drugs. You can't work in those states. MDMA so selectively turns off fear at the amygdala, leaving the other faculties intact, allowing you to talk, remember, debate, talk about your childhood, basically do psychotherapy, working these things through in real time. To be a psychedelic therapist, you need to hold space. You need to be calm. You need to manage your own neural system. You don't need to react. You need to contain. You need to let the process work. Let it flow. Let it go. In the preparation sessions, you've shown the patient that it's safe, that they can trust you. I've got you. Go for it. Let go. I'm not going anywhere. I've got you. As John Lennon said, turn off your mind, relax, and float downstream. If you're swimming in a river, powerful, strong current, like the psychedelic experience is, if you try and fight against that current, you're going to get tired. You're not going to be able to do so. Swing your legs around 180 degrees, lie back, and go with it. It'll carry you out. But it will end. It is a drug experience. I've always thought it'd be good to have a big poster on the wall in these clinics saying, you have taken a drug, it will stop. But you don't need a poster. You teach the patient this in your prep sessions. Set and setting, you're probably familiar with, the set being the mindset, the expectations. This is where we have to undo 50 years of erroneous drug policy. These people have been told for 50 years that these drugs are dangerous and addictive and are going to kill them. You need to undo all that. Another example of drug policy, increasing the harm of drugs. Setting, the physical setting. It needs to be warm, quiet, undisturbed. We use music through headphones and through the room, through speakers. Patients wear eye shades. They're encouraged to lie back and be with the experience. Some talk therapy takes place, but most of it takes place outside. We don't talk about bad trips. We talk about challenging experiences these days. Just because something's difficult doesn't mean it's wrong. If you want to run a marathon or climb a mountain, you shouldn't do it on your own. You should prepare. You should have a guide. You should have a support. And you'll be halfway through that marathon or halfway up that mountain, and it'll hurt. And you'll even wish, why did I do this? But when you get to the top of that mountain, you finish that marathon, you feel great because it was difficult. You don't say, and we don't say to people, don't run marathons, don't climb mountains because they're difficult. We say because they're difficult, do these things, but do them carefully and safely with preparation and a guide. So psychedelic experiences, when challenging, can be a breakthrough moment. I've seen this happen so many times. I've seen people survive the worst panic attacks of their lives and survive it, and in surviving it, learn that they can survive it for the first time in their lives. We use verbal support, like I say, encouraging them to be with the process, not fight it. We use physical support, holding their hand if we need to. And integration. This is the process after the course, after the drug. Making meaning. And it's a process. It takes time. It develops. Remember, we had a patient who was what we considered a treatment failure. And he left the course. This is with ketamine-assisted therapy. He left the course not doing too well, and he was very critical of our clinic. And he said it's been a waste of money, and he was angry with us all. And we said, look, it can grow. It can continue these things, yoga, Pilates, mindfulness, meditation, being with nature. And he said, oh, I'm doing that shit. And then we didn't see him for about a year. And then one day he walked into the clinic in Bristol, and we were like, oh God, it's him. And he came up to us and he said, I feel great. You were right. It unfolded. It just took some time. And thank you so much for the guidance. That was a great example of long-term integration. It doesn't all happen in that 12 to 16-week course. People are encouraged to use the tools that they've learned in the therapy to continue to improve their lifestyle. And people do spontaneously go on to have an improved lifestyle in so many cases. They sort of decide to make lifestyle changes. They move towards their positive values, the things they've always known they've wanted and haven't been able to achieve. But the difference between psychedelic therapy and non-psychedelic therapy is you experience it. You don't just talk about it. In CBT, you talk about what it would feel like to not be depressed. Let's imagine you're not anxious. With MDMA, you feel it. I had a patient turn to me on MDMA. She turned to me, she was very, very much in the process, and she said, Dr. Ben, is this what love feels like? And I didn't answer, I thought, well, hang on. You've taken a drug. This is a transient drug-induced experience. This isn't the lofty experience of love. And then before I answered, I thought, well, hang on. She feels warm, she feels held, she feels trusting, contained, empathic, safe. I said, yeah, this is what love feels like. And she went, oh my God, that's so good. I've never had this feeling. Since I was born, I've been beaten and burned and raped and abused and hurt and frightened. I've never felt so comfortable. And now I know what it feels like. I know what to expect and I know how to find it. And I said, I know. And the drug didn't do this. This was always there within you. It was just shrouded by the trauma and the pain you've been through. But this capacity to feel love has always been part of you. And now you know it's part of you. You don't need to keep taking the drug. You know it's there. So it becomes a platform for moving forward. Peter touched on this. This is not like maintenance psychiatry. This is intensive, admittedly expensive, upfront pieces of work. This is much more like surgery. This is like going in for an intensive piece of orthopedic surgery. Now, it's expensive. I don't know how much a broken femur is to mend in this country. Let's say 15 grand. Now, if you have a broken femur, you don't say, I'm not paying 15 grand. I'm going to hobble around on a broken leg and take painkillers for the rest of my life. You don't say that. And that's what we do when we don't adequately treat mental health problems. We make them hobble around and take painkillers for the rest of their lives. And one thing I often say is there is nothing more expensive than the untreated psychiatric patient. It costs millions. They need new legs, they need new livers, they don't work, they're on disability benefits, they offend, they go to prison, they have their children taken away by family courts. They're very, very expensive. It's false economy to not treat them adequately, and it costs millions. So suddenly that 10, 15, 20 grand, whatever it might cost for a treatment of psychedelic therapy, suddenly seems very economical, and it is. So almost done here. So let's imagine you've done your training. You now need to go forth, like I started this talk, and start setting up your clinics, start seeing patients, start using this opportunity. But I don't know where to start. It's such an insurmountable idea. How do I do this? How do I set up a psychedelic clinic? And this is where we've been talking about a consultancy agency, a service that can help people get going. A clinic in a box model, helping individuals around Australia to customize wherever they are on their journey, whatever they have, getting doctors to meet psychologists and pharmacists, how to write SOPs, how to set up multidisciplinary teams, how to find pharmacists, where to get the drug, how to get onto Paul's wonderful registry, which rating scales to use, how to log this so we can move towards the collection of an N equals 1,000 real-world data pool. That's unrivaled. Blows out of the water these poxy N equals 30 RCTs around the world. In 3 years, we could have 10,000 patients with meaningful outcome data in Australia. That is extraordinary if you pull your finger out. And perhaps we should also have an agency that supports clinics once they're open, providing annual assessments and appraisals, making sure that quality standards are met. This is something that's just come to us over the last 3 weeks as I've been meeting doctors and nurses and psychologists and therapists in this space. They want this. And I'm really worried that we're going to train a bunch of people here in Australia and then have a high attrition rate when they all return back to their localities and say, well, I'd like to do this. And then this audience becomes that old audience that I've always known, with only 1 or 2 of you actually going forth and doing it. That would be sad and unnecessary, because unlike any other audience, you can actually do this, but you're going to need a bit of help. So I'm going to finish by reiterating this global health crisis, the poor standards of treatment, that psychedelics represent this new technology, this time, for the first time in modern psychiatry, to combine these two very disparate fields. Psychotherapy and psychopharmacology are not normally good bedfellows. But it makes sense. Drug-assisted psychotherapy, the best of both worlds. They're very safe, they're durable, they last. You don't have to keep taking the drug. And they make financial and economic sense, but people are going to need some help. So you have this unique opportunity. Nowhere else in the world can do this. I can't think of any other new industry that suddenly sprouts up where only one country can do it. Imagine like Botox and it's only available in Afghanistan. Weird. But what an opportunity for Afghanistan, you know? Cannabis is similarly analogous because of the laws, but actually it's available everywhere. This is the only place in the world, and it is going to be the only place in the world for the next 3 years that this is available. You need to undergo the training. You need to become an approved prescriber, build your multidisciplinary teams and develop your protocols. And you'll need some help with that. Open clinics. Build and open clinics. Do not delay. Put all your data onto a registry. Paul will help you. Choose which rating scales. Collect that data. Publish that data. Lead the world in that data. And you will remain at the front in global international psychedelic medicine. Thank you.